Yes, now.
Where were we? Mm,
21.
Okay.
A 32-year-old primary gravid woman, 26 weeks of gestation, comes to the emergency department because of 8-hour history of moderate abdominal 8-hour history of moderate abdominal pain and cramping. She has no history of serious illness. Operative procedure. Her pregnancy had been uncomplicated. Vital signs are within normal limit. On pelvic examination, cervix is 6 centimeter dilated, 100% effaced. The presenting part is +1 station. Ultrasonography shows fetus in breech presentation and with 26 weeks of gestation. The patient has undergone emergent cesarean delivery, 24-hour delivery, temperature 41, pulse 130, respiration 30, hypotension. Cardiopulmonary examination shows no abnormality. Moderate abdominal examination shows moderate tenderness to palpation to the uterus. Urinalysis show 2 plus RBC and trace um, leukocyte status. Which of the following is most likely diagnosis? Okay.
Ready?
Yes.
Oh, I got mine. Sorry. 20, well, 21. It's puerperal sepsis. In an immediately postpartum patient with fever and uterine tenderness, puerperal sepsis should be suspected. Puerperal sepsis refers to sepsis presenting immediately after delivery and is typically characterized by presence of fever, abdominal pain, recurrent vaginal discharge, uterine tenderness, septic shock. Septic shock is a term used to refer to decreased organ perfusion that occurs from overwhelming infection. Septic shock is a form of distributive shock and is classically diagnosed with fever, tachycardia, tachypnea, hypotension and signs of infection, as well as leukocytosis and lactic acidosis. These factors for puerperal sepsis include C-section, uh, premature rupture of membrane, prolonged labor, manual removal of the placenta. Because of the risk of puerperal sepsis following C-section, women typically receive prophylactic dose of antibiotic at the time of surgery. It is not retained placenta fragments, also called retained products of conception, are a potential cause of postpartum hemorrhage. It causing if causing severe bleeding, retained placenta fragment need to be urgently manually removed. Removal of the entire placenta promotes uterine contraction and decreases postpartum hemorrhage. Okay.
Okay.
Septic pelvic thrombophlebitis is a real sequela of endometritis that lead to local invasion and infection of the pelvic vein walls, which cause intimal damage and thrombosis. This condition typically presents with pelvic pain and fever, which is often widely variable in course, ranging from normal temperature to febrile temperatures. Diagnosis typically occurs through blood cultures. If this patient were persistently febrile despite appropriate antibiotic treatment for endometritis and puerperal sepsis, septic thrombophlebitis should be considered.
Okay.
Okay. Okay.
A 62-year-old woman comes to the physician because of urinary incontinence for weeks. Urinary incontinence for 4 weeks. She is unable to reach bathroom. She is unable to reach bathroom quickly enough to quickly enough after feeling the need to void, she recalls um, she recalls falling on wet grass 3 weeks ago and did not notice any injury. She has GERD and hypertension. Her medication include hydrochlorothiazide and famotidine. She stopped taking hydrochlorothiazide 7 days ago because she thought it was causing the incontinence. But the symptoms have continued. She has no other medication. Blood pressure 137 by 92, examination show pelvic examination. No abnormal. Which of the following is the most likely explanation for her incontinence?
Ready?
Wait. Okay.
So it's an inhibited bladder contraction. Urge incontinence most commonly occurs as a result of the detrusor hyperreflexia or overactivity, leading to uninhibited bladder contractions. It typically presents with urge to urinate followed by leakage of a variable amount of urine. It's most associated with neurologic disorder like MS, spinal stenosis, spinal cord injuries. They may also be idiopathic. Although this patient experienced a fall, her symptoms began 1 week prior to this incident, making a traumatic neurologic cause less likely. Physical exam and lab studies disclose no abnormalities. Post-void urinary bladder residual volume will generally be within the reference range. When evaluating urinary incontinence, however, it's important to rule out an associated UTI, especially when the urinary incontinence is new in onset. Treatment of urge incontinence includes strengthening the pelvic floor, weight loss, minimizing caffeine and alcohol intake, bladder training and time voiding, and antimuscarinic agent like oxybutynin. It is not B. Loss of progesterone effect on the bladder mucosa does not typically cause incontinence. However, estrogen deficiency in the setting of menopause can cause atrophy and inflammation of the vagina and urethra, which can lead to overactive bladder or overactive bladder, yeah, or pelvic floor laxity with stress incontinence. Spinal cord injury can lead to urge incontinence, but more commonly leads to overflow incontinence caused by neurogenic bladder. Spinal cord injury leading to urinary retention is unlikely in the absence of neurologic deficits such as lower extremity weakness and perineal anesthesia. Mhm.
Okay. Is there any technique of remembering all the continents?
Um, I
Like
don't
how,
think I'm.
like
Mhm.
how you remember? You just like dealing with the questions.
Um, I don't know. Usually, the stress incontinence they will give you the whole Valsalva maneuver, and when she's coughing, she pees, and all that thing. This one, they usually will give you that same sentence, like she felt the need to pee and she wasn't even able to get to the bathroom and she pee on herself. They'll always give you that kind of sentence,
Like
and
urge
then
incontinence.
yeah, they'll always give you that. She felt the need to pee and she peed. She couldn't even get to the bathroom and she peed on herself. And then that's the stress, the urge, and then the what's the other one? The overflow incontinence. They usually will tell you. They usually will give you the residual urinary volume, and they'll say it's super high, and that's usually what I've noticed for that one. And sometimes they will give you that they have like a spinal injury or some kind of neurologic thing, but not usually. Usually they will give you the post-void urinary residual volume, and it will be high. That's kind of usually what I've seen each one.
Okay. A 27-year-old woman, gravida 4, para 1, aborta 3, gravida 4, para 1, aborta 3, comes to the physician with her 31-year-old husband of 3, first trimester spontaneous abortion during the passed during the past 15 months. The patient received the diagnosis of each pregnancy by the patient received the diagnosis of each pregnancy by serum beta ECG and ultrasonography. After diagnosis, there is no evidence of embryonic viability on ultrasonography, and spontaneous abortion occurred 7 weeks of gestation. 7 years ago, she has deep vein thrombosis of the lower extremity, deep vein thrombosis of the lower extremity while taking an OCP and was treated with anticoagulation therapy for 6 months. Physical examination of the patient and her husband shows no abnormal. Which of the following is most likely establish the cause of recurrent spontaneous abortion in this patient?
Ready?
Yes. Is it antiphospholipid antibody syndrome?
Probably yes. Spontaneous abortion is the demise of a fetus before 20 weeks gestation. Spontaneous abortion typically presents with acute vaginal bleeding and cramping. There are various stages of spontaneous abortion depending on the presence or absence of fetal heartbeat, whether the cervical os is open or closed, and the extent of fetal passage through the cervix. Early pregnancy loss occurs in the first trimester, and risk factors include age greater than 35, prior fetal demise, uterine anatomic distortion, diabetes, thyroid disorder, coagulopathy, hypercoagulopathy, substance use. The most common underlying cause of fetal death is a chromosomal abnormality, often associated with advanced maternal age. Spontaneous abortion that occurs after the first trimester is more commonly related to uterine cavity abnormalities like fibroids. So, first trimester chromosomal, second trimester fibroids, cervical insufficiency, congenital malformation, placental abruption, premature labor. Recurrent pregnancy loss is typically evaluated with karyotype analysis, hysterosalpingography, serum antiphospholipid antibody assay, and evaluation of thyroid function. In this patient with history of recurrent pregnancy loss and DVT, the most likely cause is antiphospholipid antibody. It is not B, karyotype analysis of subsequent abortus material could determine whether the patient had a chromosomal abnormality that could potentially explain her previous spontaneous abortion. However, this will require her to become pregnant again without an explanation for the recurrent losses, which will likely result in another spontaneous abortion. Hmm. Subsequent abortus. Okay. Got it.
Okay. Do you remember the diagnostic criteria of antiphospholipid antibody syndrome?
Diagnostic criteria, no.
One clinical and one lab criterion must be met to diagnose a case of antiphospholipid antibody syndrome.
Mhm.
Um, Clinical criteria like arterial or venous thrombosis, like vascular thrombosis, may be present, and pregnancy morbidity, three or more than three unexplained fetal loss before 10 weeks, three or more than three unexplained fetal loss before 10 weeks, and more than one unexplained fetal loss after 10 weeks, and one or more than one premature birth or normal neonate before 34 weeks due to preeclampsia, eclampsia, and placental insufficiency. And the three thing: lupus anticoagulant, anticardiolipin, and anti-beta 2 glycoprotein antibody. And we
Okay.
will give aspirin and warfarin. Sorry, aspirin and heparin. Warfarin is contraindicated. Fetal warfarin syndrome can happen. So three or more than three consecutive unexplained fetal death before 10 weeks, and one or more than one unexplained fetal loss after 10 weeks. Okay.
Okay.
A
Yes.
32-year-old woman, gravida 1, para 1, is brought to the emergency department because of headache for 4 days. Headache for 4 days, large piece for 3 hours, large piece for 3 hours. She has had fatigue, intermittent vaginal bleeding since delivering a healthy newborn at term 4 months ago. The bleeding has been heavy at times. The bleeding has been heavy at times. Her blood pressure is 110 by 70 millimeter of mercury. She has closed cervical os. Ultrasonography shows slightly enlarged uterus with a small clot in the endometrial cavity. There are bilateral 8 centimeter cystic ovarian mass. There are bilateral 8 centimeter cystic ovarian mass. Neurologic examination shows right-sided weakness. Hematocrit is 20. Serum beta ECG concentration is 53,000. Which of the following is the most likely diagnosis? Is it that like identiformal or choriocarcinoma, that thing?
Carcinoma. I'm between the two. Yeah. I think carcinoma. Yeah, probably that is different. But carcinoma, I feel like it's usually metastatic by the time you find it out. Okay. Ready?
Yes.
Okay. Oh, it was choriocarcinoma. Never mind. Choriocarcinoma is a malignant neoplasm of trophoblastic tissue that can develop after pregnancy. Okay, including both molar pregnancies and full-term or preterm pregnancy. It is highly aggressive and typically presents with distant metastasis. That's what I thought. With a predilection for the lung, vagina, or brain. Okay, so it was the lung. Vagina, brain, and liver. Symptoms are secondary to bleeding from the primary tumor or metastasis, and thus include vaginal bleeding, hemoptysis, dyspnea, headache, seizures, stroke-like symptoms, jaundice, and abdominal pain. Physical exam may disclose an enlarged uterus and bilateral and nasal masses, fecal lutein cysts. Lab studies will show markedly increased super high beta ECG as in this patient. Pelvic ultrasound is useful in diagnosis, um, with choriocarcinoma appearing as hypervascular uterine mass. Hypervascular. Chest X-ray is used to evaluate for lung metastasis, and further imaging such as CT scan of the abdomen and pelvis or MRI of the brain is needed based on clinical symptoms. It is treated with chemo and surgical resection, and beta ECG concentration is serially measured to monitor for progression and recurrence. It's not hydatidiform, commonly presents with persistent nausea, vomiting, first trimester vaginal bleeding, early preeclampsia, and uterine size out of proportion to expected gestational age. Hmm. As a result of abnormal fertilization of an ovum. Pelvic ultrasound will show diffuse echogenic structures in the uterus and bilateral, same thing, ovarian tecanocynsis. They are precursors to malignant trophoblastic disease such as choriocarcinoma. Hmm.
So, like in this stem, the metastasis symptom is for like there is large piece, so it metastasizes to brain. That's why it is
Mm-hmm.
choriocarcinoma.
Mm-hmm.
So, the we cannot interpret through beta ECG, isn't it?
No,
Hmm?
I don't think so.
Okay. And it metastasis to the lung, liver, brain, vagina.
Yes. Next.
A 37-year-old woman with a 2 week history of urinary urgency, frequency, burning comes to the physician for a follow-up examination. 1 week ago urinalysis showed 2250 WBC, high power filled with no protein, glucose, bacteria, ketone or crystal. Urine dipstick shows trace blood. Urine dipstick trace blood. Her symptoms have not improved with 1 week of trimethoprim sulfamethoxazole therapy. Pelvic examination shows urethral tenderness. The remainder of the examination shows no abnormality. Urine analysis remain unchanged. In addition to urine culture, which of the following is the most appropriate next step?
Protein, crystal. 37. Between A and E, urethral culture for chlamydia. Urethral. Is chlamydia causes urethritis? Cytologic, suprapubic, urethral tenderness. Okay, I'll go with chlamydia. Ah, cannot remove that. Ah, never mind. Okay, ready?
Yes.
Okay, so it's urethral culture for chlamydia. A patient with persistent symptoms of urethritis, urinary frequency agency dysuria, despite adequate treatment for a UTI with TMPSMX raises concern for other causes of urethritis such as STI secondary to chlamydia or Neisseria. Both of these organisms can cause urethritis and, if left untreated, can progress to cervicitis, PID to Bovarian abscess. Reanalysis for typical UTI shows greater than 10 white blood cells, may show red cells as because of mucosal inflammation. Bacteria are generally seen on microscopy. Chlamydia is an obligate intracellular pathogen, does not appear on urinalysis or gram stain, resulting in absence of visualized bacteria on urinalysis. Diagnosing chlamydia urethritis involves urethral culture and NAT tests to evaluate for presence of chlamydia species. Treatment consists of either azithromycin or doxycycline in combination with ceftriaxone for Neisseria. It's not a cytologic examination of suprapubic urine aspirate will not be appropriate in a patient who is able to give a clean urine sample. Hmm. Suprapubic aspiration is an invasive method of urine sampling that can be used in children that are unable to urinate and are unable to have transurethral bladder catheterization. Oh,
Okay.
okay, makes sense.
A 30-year-old woman, gravida 1, para 1, has fever and lower abdominal pain for 24 hours. 2 days ago, 2 days ago, she underwent low transverse cesarean delivery because of failure of progress in labor after 18 hours. Her temperature is 102. Her temperature is 102. Lungs are clear to auscultation. Incision is mildly tender and pink. The fundus is near the umbilicus and extremely tender. Which of the following is the most likely cause of this patient infection?
Oh, jeez. Oh, oh, Lord.
Okay.
So it's mixed anaerobes and aerobes. A recent postpartum patient with fever and severe uterine tenderness raises suspicion for endometritis. Postpartum endometritis is an acute, typically polymicrobial infection of the uterine endometrium, um, involving a mixture of aerobes and anaerobes from the genital tract. During labor and delivery, microbes from the genital tract can enter the uterine cavity and result in postpartum infection. Patients typically present with fever, severe tenderness of the uterus fundus, and mucopurulent vaginal discharge. Risk factors for endometritis include premature or prolonged rupture of membranes, prolonged labor, C-section, bacterial vaginosis, strep, galaxia colonization, manual removal of the placenta. Treatment requires broad spectrum antibiotics such as clindamycin and gentamicin for appropriate antimicrobial coverage. So endometritis is after delivery, and the chorioamnitis is during delivery.
Yes.
Okay.
Postpartum endometritis can happen after cesarean delivery. What are other risk factors? Prolonged
What
labor,
did you
sorry,
say? I couldn't hear you.
prolonged labor,
Mhm.
prolonged rupture of the membrane. Okay, bacterial vaginosis. Okay. A 37-year-old primary gravid woman comes to the physician for routine prenatal visit. She convinced 17 weeks, sorry, she conceived 17 weeks ago in vitro fertilization. Pregnancy has been uncomplicated. Physical examination shows no abnormality. The uterus is consistent in size with 17 weeks of gestation. Her maternal serum alpha fetoprotein is 7.3 multiple of the median. Like alpha fetoprotein is high, isn't it? Which of the following
Is
is the
that
most
what
likely?
it means? Is that what it means?
Yes, I think so.
Okay. Wait, down is high, so down is was it that Down syndrome is high, so down has
Alpha fetoprotein isn't it the He-Man? Hepatocellular carcinoma, endodermal sinus tumor, mixed germ cell tumor, telangiectasia, neural tube defect.
neural tube defect. Neural
Like
tube.
alpha fetoprotein is a He-Man, according to first aid. I am the mnemonic
Wait.
person. That's why I say
Yep. Ready?
fetoprotein. Yes.
So it's meningocele is a condition where the neural crest arch fails to fully form posteriorly. As a result, the dura and spinal cord protrude posteriorly out of the spinal canal. This condition is associated with abnormality in folate metabolism or a lack of adequate folate concentration neural neural crest cell differentiation and neural tube development. Maternal diabetes is an additional risk factor. It results in nerve dysfunction and paralysis. Nerve dysfunction and paralysis distal to the lesion. It is commonly diagnosed prenatally with increased alpha fetoprotein on prenatal maternal serum screening, evidence of the malformation on fetal ultrasound, and the presence of acetylcholinesterase in the amniotic fluid. Now, Down syndrome is caused by trisomy 21 and presents with the characteristic facies, intellectual disabilities, single primaries, AV, septal defects, duodenal atresia, and increases for ALL and Alzheimer's, associated with increased um, human
Down
chorionic
syndrome is
protein,
high up, like
high
A beta HCG and inhibin is up.
beta hCG and inhibin, as well as decreased alpha fetoprotein and S3O concentrations on second semester. Okay, beta hCG and inhibin. Okay, next.
Can you give me 2 minutes? I'm coming. Just 2 minutes.
Yes.
Okay.
Yes. Hello.
Yes.
Okay.
A 28, sorry, immediately after Immediately after cesarean delivery because of abruptio placentae, a 25-year-old woman loses consciousness. She has estimated blood loss 1200 ml. Her pregnancy was uncomplicated. Temperature is normal, pulse 120, respiration 26, blood pressure 60 by 40. Examination shows frothy pink sputum. Examination shows frothy pink sputum. Bilateral bruises are hard on auscultation. The fundus is firm. Lab is hemoglobin 7, leukocyte count 8,000, platelet 60,000. So anemia, thrombocytopenia, bleeding time is high 9, PT is high, PTT is high, thrombin time don't know, and plasma fibrinogen is low, and fibrin degradation product is high. Which of the following is the most, sorry, chest x-ray show pulmonary edema, ECG show tachycardia. Which of the following is the most likely diagnosis?
PT is high and PTT is high.
Looks like DIC. Okay,
One moment.
it's not eclampsia, isn't it? Can be hypovolemic shock, but in hypovolemic shock, is there any possibility of PT-PTT to be raised?
Don't know. So you think it's amniotic fluid?
I'm thinking because in septic shock, for septic shock to happen, leukocyte count should be raised. Leukocyte count is normal.
For septic shock to be released. Yeah, it's not septic shock. But amniotic fluid is not the same as PE. So shouldn't it be? Or maybe. Maybe. Okay. Okay. So it's amniotic fluid. Amniotic fluid embolism is a rare and potentially fatal complication of childbirth caused by amniotic fluid entering the maternal circulation. It most commonly occurs during delivery or in the immediate postpartum period. It typically presents with acute onset of shortness of breath, altered mental status, and unconsciousness, and bilateral wheezing. Signs of fetal distress can also occur if the fetus remains in uterus at the time of occurrence. Vital signs which show tachycardia, hypoxia, and severe hypotension. Hypoxia. Okay. The patient can quickly decompensate into cardiovascular collapse and cardiopulmonary arrest. Chest X-ray may show pulmonary edemas in this patient. Treatment is generally supportive, with patients often requiring fluids or blood products and mechanical ventilation. Complications include diffuse bleeding from venipuncture sites, the vagina or C-section delivery incision caused by DIC. In addition to increased rates of fetal and maternal mortality, acute DIC presents with thrombocytopenia, microangiopathic hemolytic anemia, prolongation of PT and PTT, decreased fibrinogen as a result of consumptive coagulopathy with rapid fibrinolysis. It is not hypovolemic shock occurs secondary to significant reduction in patient's intravascular volume, most commonly related to hemorrhage, dehydration, and GI losses, which results in decreased stroke volume and cardiac output. Though this patient had significant amount of blood loss with her C-section, her hemoglobin concentrations remains above the typical transfusion threshold, and hypovolemia will not explain her pulmonary edema. Makes sense, and coagulation abnormalities. Mm, Makes sense. Okay.
Okay. A 39-year-old woman, Gravida 1, Para 1, comes to routine health maintenance examination. Mens have occurred Mens have occurred irregular intervals since menarche at the age of 14 years. Her last menstrual period 6 months ago and was extremely heavy. She has declined to take hormones to regulate mens because she does not want to have a monthly menstrual period. She only her only child was conceived 8 years ago after she was treated with clomiphene. She has hirsutism since adolescence. Which of the following is the most which of the following serum concentration is most likely to be increased?
Ready?
Isn't it PCOS?
Probably.
Okay.
Ready?
Yes, yes.
So, oh, wait, what am I? Oh, it's testosterone. PCOS presents with irregular menses, infertility, hirsutism, often in patients with increased body weight. It requires two of the following for diagnosis: oligoanavulation, PCOS on ultrasound, and clinical or biochemical signs of hyperandrogenism and hyperandrogenism. It is associated with signs of insulin resistance such as acanthosis nigricans and increased glucose level. PCOS is associated with an abnormal hypothalamic hormonal feedback response, which leads to increased LH in comparison to FSH, as well as markedly increased androgen production from the thicker lutein cyst. Oh, okay, got it. This results in an increased serum concentration of testosterone. Treatment includes weight loss, combined OCPs for menstrual regulation, and spironolactone or ketoconazole for hirsutism. Clomiphene stimulates ovulation and can also be used for individual desiring. Oh, I forgot again what clomiphene. It's for individual
Ovulation.
desiring,
Just remember the ovulation inducing drug.
but I forgot the mechanism again. I don't know why I can do these ones and the Luprolite. I don't know why I just cannot remember them.
Clomiphene is
No,
SARM,
no.
SARM, selective estrogen receptor modulator. I have
Oh,
already
no.
given this into the
Yeah. Oh, no,
yes,
I remember the Luprolite. Luprolite in lieu of GnRH. So Luprolite is like a GnRH agonist,
GnRH
similar.
agonist. It acts as a GnRH agonist.
Yeah, that one I remember. It's the
And
clomiphene that I'm always forgetting.
like clomiphene, tamoxifen, and raloxifene, these three are SARM, selective estrogen receptor modulator. Like it is antagonist against the estrogen receptor in the hypothalamus.
Okay,
Clomiphene also uh, acts as an antagonist at the estrogen receptor in the hypothalamus.
okay, got it. If the patient is diagnosed with diabetes mellitus, oral medications like metformin or insulin may be necessary. Potential complication of low standing PCOS is endometrial cancer caused by chronic anovulation resulting in prolonged exposure of the endometrium to unopposed estrogen. Okay,
Next,
next.
a 16-year-old girl is brought to the physician. A 16-year-old girl is brought to the physician by her mother because of 18-month history of increasingly severe menstrual cramp. Increasingly severe menstrual cramp associated with diarrhea and vomiting. The symptoms cause her to miss 2 days of school. The symptoms cause her to miss 2 days of school, yeah, school each month, and her school performance is being to decline. Menarche was at the age of 13 years. Mens occur at regular intervals, 28 days interval. She is not sexually active. She is 5 feet 5 inch tall, weight is 57 kg, BMI is 21 kg per meter square. Physical examination shows no abnormalities. Pelvic examination shows normal appearing. Pelvic examination shows normal appearing external genitalia, vagina, and cervix. The uterus is small, mobile, and non-tender. There are no adnexal masses or nodularity. Which of the following is the most likely cause of this patient's symptoms?
Mm.
Okay,
Oh my goodness. Okay. So it is primary dysmenorrhea. Primary dysmenorrhea is defined as menstrual pain that accompanies each menstrual cycle but is not associated with underlying pathology. In order to diagnose primary dysmenorrhea, causes of secondary dysmenorrhea must be ruled out. These may include endometriosis, fibroid adhesions, PID, adenomyosis. Many of these can be reasonably assessed on pelvic exam, which in this case did not show any abnormality. Primary dysmenorrhea typically presents with pain in the lower abdomen and pelvis, which may radiate to the lower back and thighs. It is often accompanied by nausea, diarrhea, headaches, and flushing. It can be attributed to uterine vasoconstriction in response to an excess prostaglandin. Uterine vasoconstriction. Okay. Those treatment targets this pathway with medications such as NSAIDs and topical heat therapy. Combined OCPs or progesterone or like IUDs may also be utilized to regulate these symptoms if persistent. So a lot of prostaglandin causes the uterus to constrict. Okay. It's not endometriosis because endometriosis denotes the presence of endometrial tissue outside of the uterus and classically presents with symptoms of dysmenorrhea, dyspareunia, and dyschezia. So pain with sex and bloody, I don't know.
like
The stand
dyschezia, painful defecation.
or painful defecation. The standard for diagnosis is a diagnostic laparoscopy which evaluates endometrial implant lesions on the perineum. Pelvic exam often discloses tenderness of the uterine wall and surrounding structures with possible uterine immobility. That's the key. Secondary to pelvic adhesion, immobility. Okay, next.
A previously healthy 23-year-old primary gravid woman, 10 weeks of gestation, has had nausea and vomiting for 4 weeks. She can tolerate small amount of food intermittently, but usually vomit 3 to 4 times daily. She is 5 feet 2 inch. She has lost 1.8 kg and is currently 54 kg. Ultrasonography shows a viable fetus consistent with 10 weeks of gestation. Which of the following is the most likely to affect her condition of the fetus? Is it
Ready?
hyperemesis gravidarum?
Um, guess, yeah.
Okay.
Yeah. Severe nausea is not significant adverse effect. Severe nausea with inability to maintain adequate oral intake is a common presentive feature of hyperemesis gravidarum and can lead to clinically significant levels of dehydration and starvation ketosis. Hyperemesis gravidarum is usually associated with weight loss in early pregnancy and extends past the first trimester. When typical morning sickness resolve, tachycardia, mild hypotension, and signs of dehydration like dry mucous membranes will be expected. Vital signs and physical exam. Lab studies disclose ketones in the blood and urine, as well as hyposmolar hyponatremia and hypokalemic, hypochloremic metabolic alkalosis caused by dehydration and volume contraction. Ketosis can also contribute to a secondary metabolic acidosis, as hyperemesis gravidarum is associated with mother pregnancy. It's important to exclude this condition with pelvic ultrasound and assessment of concentration of beta ECG. Treatment of hyperemesis gravidarum includes vitamin B6, IV fluids, antiemetic, and severe cases TPN. When treated appropriately, there are generally no long-term, it's mostly effect, okay, no long-term adverse effects on the developing fetus. Small developmental delay is associated with a variety of conditions, including chromosomal abnormalities, lysosomal storage disorders, sex chromosome disorders, neurologic disorders, endocrine abnormality, vitamin disorders is not associated, is not a suspected consequence of hyperemesis gravidarum. Okay.
In hyperemesis gravidarum, we see the ketone body, isn't it?
Yeah.
Okay. A 27-year-old primary gravid woman, 8 weeks of gestation, comes to the physician because of one-day history of migraine. She has a history of migraine treated with sumatriptan. She reports that she has not taken any pain relief medication for her headache because of concern regarding possible harm to the fetus. Vital signs are within normal limit. Physical examination shows a uterus consistent in size with 8 weeks of gestation. Which of the following is the most appropriate pharmacotherapy?
Hmm. Don't know. Ready?
Yes.
It's acetaminophen. Migraine headache is a frequent occurrence during pregnancy. Acetaminophen is considered safe during pregnancy and breastfeeding and is useful for treating acute pain associated with migraine headache. Acetaminophen is selectively inhibits COX enzymes in the central nervous system, resulting in analgesia. Adverse effects include hepatotoxicity if taken in excess. Importantly, migraine and tension headache must be distinguished from other types of headache that may indicate serious conditions such as preeclampsia, idiopathic intracranial hypertension, meningitis, subarachnoid hemorrhage, cerebrovenous sinus thrombosis, and pituitary apoplexy. Barbiturates is a barbiturate. In addition to their addictive properties, barbiturates have been shown to cause a variety of birth defects, including neurotube, tetralogy of Fallot, cardiac septa. The fetus is more susceptible to these teratogenic effects during the first trimester. Ergo is an Ergot are contraindicated in all trimester of pregnancy because of uterotonic and vasoconstrictive property that can cause fetal distress, birth defect, and miscarriage. Meperidine is a synthetic opioid and should not be used in pregnancy as a result of dependence and addiction, and because of risk of neonatal opioid withdrawal. And so matriptan is useful for the treatment of migraine. However, there is evidence that it may lead to an increase incident of behavioral problem when used in the first trimester. There is no conclusive evidence that somatriptan exposure can cause birth defects. However, acetaminophen is well evidenced as safe in pregnancy without teratogenic effects.
Okay. A 33-year-old primary gravid, a 33 a third sorry a 17-year-old primary gravid patient a 17-year-old primary gravid patient has been in labor for 15 hours. She made no progress. for the past 3 hours. Notebooks for past 3 hours. The cervix is 5 centimeter dilated, 80% if vertex is 2 plus station contraction occur every 5 minutes. Assuming a normal sized full term fetus and a clinically adequate pelvis, which of the following is most appropriate next?
Ready?
Yes.
So it's augmentation of labor with oxytocin. Labor consists of three stages. We've been reading this for 2 days. So the first stage is, I swear it's like the same one.
I
The
am
first,
waiting for your expression.
I mean, at this point, if we miss one of those questions during the exam, it's gonna be like, man, like we've read this like two, three times, but I don't know. The first stage encompasses the start of labor, contraction, and cervical change until compression of the cervix until the cervix is super dilated. The second stage includes from the cervical that's super dilated to the birth of the baby, and the third stage is delivery of the placenta. First stage is divided into latent and active stage based on the degree of cervical dilation, with the active being latent being 1 to 4 and active being 4 to 10 dilation. The active stage of labor can be protracted, so 4 to 10 can be protracted, which occurs when the cervix is dilated at less than when the cervix is dilated at less than 1 to 2 centimeters per hour. Or it can be arrested when there is no cervical change for greater than 4 hours with adequate contraction or 6 hours with an adequate contraction. As in this patient, so this patient has what? No progress for so he has what? Protraction, I'm guessing. Abnormal progression of the active stage of labor um, can be caused by hypotonic contractions, cephalopelvic distortion, and non-occiput anterior fetal presentation. Inadequate contractions are defined as occurring less than 3 to 4 times in a 10-minute period with a strength of less than 200 Montevideos. They say contractions every 5 minutes. Okay, they didn't say how many. Montevideo units are calculated by assuming the strength of each uterine contraction. It uterine peak pressure minus baseline pressure over a 10-minute interval. This patient demonstrates contraction every 5 minutes, which raises the concern of inadequate contraction. Okay, contraction every 5, so one contraction, so 2 per 10. Okay. Protraction and arrest of the active phase of labor can be managed with oxytocin to augment uterine contraction and prostaglandin to assist in cervical ripening. With cesarean delivery, utilizing of oxytocin augmentation doesn't work. Okay, I think all the others are. So the is the active phase. It's not the latent phase. The active phase that can be protracted or arrested. It's not the whole second stage of labor. It's just the active phase. Okay, got it.
Yes,
Mhm.
not whole. In the active phase, the arrest and the protraction.
Okay, next.
Okay. And arrest happen in the second stage of labor, isn't it? First stage is onset
What do
of
you mean?
like the arrest and protection usually happens in the second stage of labor.
Arrest and protection usually happen in the second stage. No, sorry. It's the first stage. Sorry. It's the first stage. First stage active phase.
Okay, yes. First stage is protection and arrest.
Yeah. Yeah.
And the arrest is like no cervical change in 4 hours with adequate contraction and no cervical change in 6 hours without, sorry, with inadequate cervical contraction.
Mm-hmm.
First stage. Okay.
Mm-hmm.
These things are a bit confusing.
Yeah, it gets a bit confusing because you have to remember the three, four, the one, more than one, less than one thing in 1 hour. This, yeah, it kind of gets a bit confusing sometimes. But you see that there is always those questions. In all the CMS that we've done, there is always one or two of those questions.
So these things are important
Yeah.
because these
Yeah.
things are a bit confusing. In the exam, our brain might not work dealing with this type of
Mm-hmm.
question. Okay,
Mm-hmm.
not our mine. Okay. A,
No, hour.
a 23-year-old woman, Gravida 1, Para 1. Gravida 1, Para 1 comes to the physician because of increasingly severe pain on the left breast over the past 3 days. She now describes the pain is she now describes the pain as excruciating. 5 days ago, she has delivered 3.7 kg newborn vaginally after an uncomplicated labor. Her pregnancy was complicated by oligohydramnios. Labor was induced and at 37 weeks of gestation. Her postpartum course has been uncomplicated. She is breastfeeding and her temperature is 37.5 degrees Celsius. Examination shows a tender edematous area on the lateral aspect of the left breast that is not erythematous or warm. Examination of which of the following is the most appropriate next step.
Ready?
Wait 1 second. So
Mm-hmm.
there is that is not erythematous. Okay.
Okay, so is application of heat to the area. This patient presents with painful breast lump whose appearance coincided with breastfeeding. Painful breast lump consistent with galactocele. Yeah. Galactoceles are retention cysts that form as a result of obstruction of a lactiferous duct. They may be painful or painless and tend to occur during lactation or shortly after cessation of lactation. Patient may develop secondary infection with formation of a breast abscess, which presents with fever and localized redness and calor overlying the abscess. Diagnosis of galactocele is facilitated by mammography and ultrasound. Placement is supportive with massage, application of heat, although patients with refractory symptoms may benefit from therapeutic fine needle aspiration. It's not incision and drainage is not preferred over fine needle aspiration for the treatment of a refractory galactocele or breast abscess, as it is more invasive. So, and has increased rate of scarring and unfavorable cosmetic outcomes. Okay, fine needle aspiration. Okay.
Okay. A 35 year a 35 sorry A previously healthy 47-year-old woman comes to the physician 3 weeks after she noted a lump in her right breast during self-examination. Physical examination shows 3 centimeter mass in the upper quadrant of the right breast. Mammography shows no abdominal. Ultrasonograph shows cystic component. Fine needle aspiration biopsy yields shallow, cloudy cloudy straw colored fluid. The mass is still present after the mass is still present after the aspiration. Which of the following is the appropriate next step? Straw colored fluid aspiration course. Okay.
Ready? This biopsy of the mass. Breast cancer encompasses many types of carcinoma, including invasive ductal and lobular carcinoma, medullary carcinoma, inflammatory breast cancer, cystosarcoma phylloides. The most common type is invasive ductal carcinoma, which typically present as a palpable immobile breast mass, which may demonstrate features such as spiculated margins and microcalcifications on mammography. They can be associated with pathologic nipple discharge. Evaluation of a breast mass first involves imaging with either mammogram if over the age of 35 or ultrasound if under the age of 35 to evaluate whether the palpable mass has feature concerning of breast cancer. This is because younger women breasts are denser and more challenging to evaluate by mammogram may be followed by ultrasound. In this case, the mass persisted after ultrasound guided aspiration of fluid, indicating it's like the simple cyst. Therefore, it should be biopsy to rule out breast cancer. Biopsy is invasive and reserved for cases of moderate to increased clinical suspicion after investigation with diagnostic imaging takes place. You want me to read another one, or
No,
that's
no.
fine? Okay.
A 23-year-old woman, gravida 2, para 1, admitted in labor at term, admitted in labor at term. Her pregnancy had been uncomplicated. Cervix is 1 centimeter dilated, 75% effaced, and vertex is -1 station. 2 hours later, 2 hours later, the cervix is 5 centimeter dilated, 75 centimeter effaced, 75% effaced. The vertex is at 0 station. Fetal heart rate 140. 4 hours later, the cervix is 6. The rest of the examination is unchanged. Which of the following? Prolonged latent pus. 2 centimeter, only 1 centimeter. There is adequate contraction, is it?
Mm, I don't know why you talking about they didn't say anything about contractions here.
Is it protected active phase of labor?
Protection of descent. And between that and protection of descent. So she came at 4 centimeters, then she went to 5, and then from 5 to 6.
5
So
to
she's
6
already,
or 5 to 6 on 4 hours.
yeah, so it's probably protected active phase.
Okay, let's see. We need to be master on this.
Wait, why am I okay? Wait, did I miss something?
Sorry.
Oh, they skipped that question. It's not here. I was like, wait, what's happening?
Okay, let's
They
see
skipped.
from the Gemini.
Yeah. Mhm. Let me see if I can copy. Don't even let me copy. Make
Copy
it
and
was.
do paste.
Yeah, doesn't even let me copy. Okay. Oh my lord. Copy.
Maybe you, as you use like the final answer is C.
What did they say the final AC?
Yes.
Okay, so we got it right then. Why is it not? Okay, maybe I.
Like sending you
Oh,
the
I got it.
explanation and then you got
Oh,
it.
I see it. Mm-hmm. The active phase of labor is that's the C, protracted active phase of labor. The active phase of labor is characterized by more rapid cervical dilation. Multiparous woman, a dilation rate of less than 1.5 centimeter per hour is considered protracted. A dilation rate is the likely active phase from 5 to 6 is 0.25 centimeters per hour, which is lower than expected. It's not the protraction of descent. Protraction of descent refers to a slower than expected descent of the fetal presenting part in the active phase of labor. While the station has progressed from -1 to 0 over 6 hours, the primary concern here is the slow cervical dilation. Hmm, okay, got it.
Okay. So Gemini give right answer.
So what?
Sometimes it give wrong answer, but it's
No
no
one
problem. Okay. A 32-year-old woman, gravida 4, para 3, 38 weeks of gestation, is admitted to the hospital 8 hours after premature rupture of the membrane. Pregnancy has been uncomplicated. Previous pregnancies were uncomplicated with spontaneous vaginal delivery. 3.4 kg, 3.6 and 3.7 newborns at 37 to 39 weeks of gestation. She has no history of illness. Her only medication is prenatal vitamin. Temperature is 99, pulse 80, respiration 16, blood pressure 112 by 65. The cervix is 1 centimeter dilated, 80% effaced. Labor augmentation with oxytocin is begun and resulting in contraction 2 to 3 minutes apart. The cervix is now 8 centimeter dilated, 100% effaced. The vertex is +2 station. Heart temperature is 102. Pulse is 110 per minute. Respiration is 22. Blood pressure 105 by 58. The baseline heart rate is 175 per minute. Mild variable deceleration. Uterus is tender. Which of the following is the most appropriate uh, next step in the management? 1 centimeter dilated. Oxytocin dose.
Ready?
Okay.
Okay, so it's antibiotic therapy. What am I? Chorioamnionitis is a polymicrobial bacterial infection.
Like during the delivery, as the temperature is high, that's why you pick chorioamnionitis. What are the clue you
During,
found? I missed this thing. That's why I am asking.
let's read it to
Okay.
see the clues. I think I just dismissed all the other ones. I didn't know. I just deleted all the other ones. Chorioamnionitis is a polymicrobial bacterial infection of the fetal membranes and commonly occurs in premature or prolonged rupture of membranes because of the migration of vaginal flora into the uterus. Other risk factors include repeated digital vaginal exam, meconium stain amniotic fluid, and genital tract infections. Maternal fever and leukocytosis are characteristic. Maternal fever and okay. And the uterus may be tender to palpation with the presence of purulent amniotic fluid. Further evaluation of the amniotic fluid may disclose a positive gram stain with culture, numeral leukocytes, low glucose concentration. Fetal heart rate ratio will show tachycardia, of course, because of the fever, maternal fever. Complication includes uterine atony, wound infections, pelvic abscess, sepsis. Treatment consists of delivery and IV anesthesia.
Hello?
Oxytocin therapy because they gave oxytocin and that's when the whole thing started.
Yes.
So yeah, let's not give oxytocin. And we don't use forceps and vacuum extraction until the second stage of labor, and she's still in the first stage. So we know, I know it's not those two. Does it make sense?
Yes.
Yeah.
Forces,
And
then why not immediate? Because cesarean delivery.
it says here the not immediate cesarean delivery because you first have to try. Oh, it says because the mom doesn't have it's not unstable, and the fetus also they are not unstable. And then
Heart
the
rate, fetal heart rate is higher. Okay.
yeah, she,
Yes.
hmm
And
but
there is
in
mild variable deceleration also. Yes.
yes, but there's also said that she's also progressing to that the active phase is progressing normally. Um, I guess you cannot go with the
Yes.
fetal on step because I mean, yeah,
After
you
giving
have
oxytocin, the cervix is now 8 centimeter.
yeah, and I think she's progressing fine, right? She came with 1 centimeter, then she went to 8. Yeah, so
Yes.
she's
Yes.
progressing fine. So they're saying that just give the medicine and keep monitoring to see if she's still progressing fine and if the fetus doesn't get like super unstable or the mom doesn't get super unstable. I guess
These things is called the induction, isn't it? Like people told the induction of labor. Like induction is done by this oxytocin. You got my point, what I'm trying
mm,
to
mm,
say.
no, no. Hello?
Yes,
Uh-huh. No, I don't understand what you're trying to say.
like what is induction of labor?
Mm, I guess yeah, when you give oxytocin, so there are contractions in the cervical thing, and I guess yeah, this induction of labor. Medical procedure stimulate your uterus to begin contractions leading to okay. So you give something so the uterus can start contracting. Yeah. But it doesn't say with methods can include like giving prostaglandins. So there is a lot of methods. You can do oxytocin too. You can give prostaglandin. Yeah. So there is a lot of ways to do it, but basically you want to induce the contractions. Does it make sense?
Yes.
Okay.
Okay. Have you done your breakfast?
Oh no.
Okay, then you do it.
Okay.
Okay, bye bye. Very comfortable in dealing questions. Like you know the concept, I know the concept, so
Mm-hmm.
you easily pick up, and I easily pick up the
Mm-hmm.
concept. In the world, the question is bigger, I know, but that was not. Uh, it was not that easy actually. Like this,
Yeah.
if we start doing CMS from before eWorld,
Mm-hmm.
we will do lot of struggle.
Oh, you think so?
I
Okay.
think so
Okay.
because these questions, you are thinking that these questions are easy because you now you know all the concept. That's why you are feeling easy.
Oh. I don't think they're easy, but I'm just wondering why we're going really fast on those. And it's like 50 questions, but we're able to do them in like two
No,
days.
we like Some people actually do like 120, 118. Some people actually do 200 questions per day. There are some
of
people.
of CMS.
No, no, not CMS. Like UWorld and other stuffs. Like they actually told
Yeah,
to do,
I read that on Google, but I'm like,
but
I cannot
but
do it. I
we
just
can, like previously before studying with alone, I try to do lots of question. But what happens in there? Like you can
mm-hmm,
do plenty of question, but you will
mm-hmm.
do the same mistakes again and again if you
And
don't
again and again.
get the catch.
But were
Like
you able to do like 200 questions in one day?
I can do like 4 blocks per day, like 160. I can.
160. And then you read the explanation too.
No, if you do 160 question per day, you are not able to go through
To read,
explanation what
yeah.
we are doing. Like you can see, oh,
That's
this is right,
true.
this is wrong. Okay, why it is wrong?
Mm-hmm.
Just go in that way. But I have found that I am doing the mistakes again and again because all the concepts
Mm-hmm.
is forgettable actually.
Mm-hmm.
Like we are doing eWorld for so long. People tell the eWorld for to yeah, before like 5 to 6 years earlier, like when uh,
Mm-hmm. Mm-hmm.
the USML is not popular in our country. They are actually told to
Mm-hmm.
do Kaplan and do lots of stuff first, then to deal with the
Mm-hmm.
UWorld.
Partner.
Yes.
Mm-hmm.
So I think that that was a waste of time.
Mm-hmm.
Doing plenty of
Hmm.
stuffs like doing Kaplan and these and that. Actually, you can
Yeah.
build concept, but you are not able to perform the questions in the actual exam.
Yeah. And the actual exam, yeah. That's true. I did Kaplan.
People do people actually waste plenty of money just doing Kaplan coaching.
Yes, coaching. Yeah.
Yes,
Yeah.
it is very costly as far I know. Like
It is. It
so,
is.
what happened after doing that question? Nothing happened. you
Mm-hmm.
you can build your concept, but it will not help in tackling the question in the exam because a question tackling and building
Exam, yeah.
concept is a different thing.
Mm-hmm. That
That's
is true.
my thing. Like I think that studying with people is very good than studying in the Kaplan. Like going through the Kaplan. I I ask you plenty of questions. I ask you to can you make me understand why I am doing so? Because you are telling what you have understood. You are not my teacher.
Mm-hmm.
Like you have studied this
Mm-hmm.
question and you got something. That's why you
Mm-hmm.
understand this question and that's why you made this question correct, isn't it? Like you have seen something.
Yes.
I want to see that thing
Yes.
what you have seen. That is, don't want to be a teacher. You got my point what I am trying to focus.
Yes. Yes.
Like
Yes.
the teacher know everything and he will go through in his way and you are not able
Mm-hmm.
to pick all the things what
Yes.
he is saying. But I can see,
Mm-hmm.
but I can see from your eye and you can see from my eye. If we,
That's true.
yes, if we just accumulate our knowledge together, we can
Mm-hmm.
we can rise one step ahead. That's
Mm-hmm.
my thing. Like that's what I am thinking. Y-
That's true. Even now, I feel.
like
I think our thing is
like
working because even now I
like
feel
you
more.
know biostat very well. I know that you have a good concept in biostat, but why I'm pushing you that study biostat like at least 4 to 5 questions, because I think that it is very forgettable thing. L-
Mm-hmm.
If you don't do biostat for a month,
Yes.
you are not able to pick the answer in the question, even if it is mean
The
median mode.
answer. Mhm. Mhm.
So
That's true.
so
That.
there are plenty of things, plenty of conception, but
Mm.
okay, let's see what happens in our exam. I don't know future, but whatever we have learned, it will work in our like it will help in your lifetime. I think so.
Yeah.
Like
Yeah.
learning does not waste.
Waste. Yeah.
Yes.
Okay.
Okay. I have talked a lot. Let's study. Okay.
Yeah.
Okay, a 67-year-old woman, gravid 3 para 3 comes to the physician because of 1 month history of rapidly increasing lower abdominal mass. Rapidly increasing lower abdominal mass. 20 years ago, she underwent radiation therapy of the pelvis for early cervical cancer, and the uterus was not removed. And the uterus was not removed. She has been receiving estrogen progesterone replacement therapy since then. She smoked. Uh, she smoked 2 packs of cigarette daily for 40 years. Examination show normal appearing vulva, vagina, and cervix. The uterus measures 16 centimeter. She undergoes exploratory laparotomy, total abdominal hysterectomy, and bilateral salpingo-oophorectomy. Pathological evaluation show uterine sarcoma. Which of the following is the most likely cause of this pathologic condition?
Mm.
Okay.
No. Okay. So it is the pelvic radiation therapy. Uterine sarcoma is rare malignant proliferation of the myometrium or the stroma of the uterus that most commonly occurs in postmenopausal women and is typically present with postmenopausal bleeding, abdominal pain, bloating, and rapidly enlarging pelvic mass. Physical exam will disclose enlarged uterus and ultrasound will show heterogeneous mass with possible foci of internal necrosis. Typical evaluation includes endometrial biopsy as well as biopsy of the mass itself, while treatment involves total hysterectomy with bilateral salpingo-oophorectomy, as well as lymph node dissection, chemo. Risk factors for the development of uterine sarcoma include pelvic radiation therapy, history of retinoblastoma, and long-term use of tamoxifen. Cigarette smoking increases the risk for lung, urothelial, so bladder, pancreatic, and squamous cell carcinoma of the skin, cervical, and anal canal. Does not increase the risk of uterine sarcoma. And it's not estrogen. Excessive estrogen plays a role in the development of endometrial hyperplasia and endometrial cancer because of this risk is decreased when used with progesterone. Okay, next.
Okay. A 77-year-old woman, uh, gravida 7 para 5 aborted 2, gravida 7 para 5 aborted 2, comes to the physician because of a mass protruding from the vagina for a week. She feels something moving with the mass. She has had severe low back pain, or she has had severe low back pain for 6 months. 8 years ago, she underwent vaginal hysterectomy and anterior and posterior colporrhaphy for treatment of uterovaginal prolapse. Which of the following is the most likely diagnosis? Okay,
Uterovagina, uterovaginal prolapse. Oh, back pain. Interesting. Okay, I don't know. I don't know. Give me clue. Back pain, back pain, back pain. I feel like that's the clue, but I don't know. Okay, so it's enterocele. Pelvic organ prolapse occurs secondary to pelvic floor dysfunction and weakness, resulting in herniation of abdominopelvic organ, which cause mass effect and protrusion along the vaginal wall. Okay. POP, pelvic organ prolapse, may occur secondary to prolapse of any of the several visceral organs. It's more common in individuals who have had multiple childbirths, advanced age, obesity, which are all at risk factors for pelvic floor dysfunction. Even though this patient has had her uterus removed along with a anterior and posterior colporrhaphy, what does that mean? For
Colpo
prior
means
heterovaginal.
vagina. Anterior
Mhm.
colporrhaphy. Raphy means repair. Anterior colporrhaphy and posterior colporrhaphy. Like uh, in the prolapse, anterior colporrhaphy for uh, yes, colpo. I know
Hello?
that. Yes, can you hear me?
Mhm. Now, mhm. So
So
repair of the vagina.
yes,
Okay. Additional viscera may still prolapse into the vaginal wall through other portions of the pelvic floor. These herniations impair urinary, defecatory, and sexual function. When the intestines herniate to the pelvic floor and impress upon the vaginal canal, it is referred to as enterocele. The small bowel usually prolapses into the superior wall of the vagina with a visible bulge, usually present on physical exam. The patient may feel a sensation of peristalsis, causing the feeling of something moving within the mass. Oh, that's what it means. POP tends to be slowly progressive if not treated. It's not cystocele is common in multiparous women as a result of, yeah, which causes the bladder to prolapse into the anterior vaginal wall. It is associated with stress urinary incontinence, but can also cause urinary retention and incomplete bladder emptying. Physical exam most commonly discloses a bulge in the anterior vaginal wall, and urethral hypermobility is absent. Okay, it's not, what was that, my other thing? Urethrosil is caused by prolapse of the urethra into the vaginal wall, anterior vaginal wall, and is common cause of stress incontinence, especially in multiparous women. Okay, I
okay.
think that's all I was.
A 40-year, sorry, a 27, a 27-year-old woman, a 27-year-old woman, gravida 3 para to 32 weeks of gestation, gravida 3 para to 32 weeks of gestation, comes to the physician for a routine prenatal visit. She says that she feels well and has not had a uterine contraction. Reports the baby has been very active. She reports that the baby has been very active. The patient has had 1 kg weight gain since her last visit 2 weeks ago. She does not drink alcohol and quit smoking after she learned she was pregnant. She is a bartender. Blood pressure is 120 by 70. Fundal height is 28 centimeter. Fetal tone is 150 centimeter. Leopard maneuver confirmed. There is cephalic presentation. Which of the following is the most next step?
Hmm.
So what does she has? Fetal weight is she fundal height is 28 centimeter, but she is 32 weeks of gestation. It is IUG or
So, No, really, it doesn't know because everything else is fine. But I wonder if we should just do ultrasound to check for the since it's 28 and shit. Oh, it's normal and we just follow up in. Oh, I guess let's do ultrasound. Fine. It's either that or follow up in 2 weeks because everything else is normal. Okay,
Okay.
ready?
Yes.
Okay, it's ultrasound. Fundal height is often used to estimate gestational age. The distance in centimeters between the pubic symphysis and the top of your uterine fundus approximates the gestational age in weeks. Okay. Typically, gestational age is calculated from the last menstruation. When there is discrepancy between these two measurements, the most appropriate next step is ultrasound to assess the fetus through um, yeah, parameters for accurate dating or in fetal size. Measurements of the fetal crown rump length, biparietal diameter, femur length, abdominal circumference can be used to accurately date the pregnancy. Ultrasound guided gestational age measurements are the most accurate during the first trimester. Ultrasound can also determine other causes for fundal height smaller than expected, such as IUG, or larger than expected, including multiple gestation, adenoformal fetal macrosomia. In this case, the patient is likely experiencing, you're right, IUG, which can be secondary to enteroplacental insufficiency, congenital infections, or maternal substance use. Follow up in 2 weeks will be appropriate if this patient had a healthy gestation at 36 weeks. Yeah, okay. However, as this fetus is potentially experiencing IUG, IUGR, performing ultrasound is pertinent to confirm the diagnosis. Okay.
Okay. The basal body temp the basal body temperature the basal body temperature graph was obtained 22 weeks of nullly gravid woman 22 weeks of nullly gravid woman who has been unable to conceive 18 months. Mens occur at regular 28 days of interval. Which of the following hormones most likely increase in basal body temperature? Basal body temperature. Is it okay?
The HCG, So she is menstrual.
Menstrual bleeding, then
Okay.
fast
Oh my
for.
God. Okay. So it's 28, 28. Or is it
So
28,
how it
28?
can calculate this thing?
It's 14, 14 is 28. So the first 14, so L is probably LH. Oh my God. I don't know why my thing is doing that. Okay. Ready?
Yes.
Oh, never mind. It's progesterone. The first half of the menstrual cycle is referred as the follicular phase, which begins with menses and is variable in length. During menses, FSH and LH concentrations increase and stimulate the developing follicle. So, follicular phase, FSH. The follicle produces estrogen, which leads to proliferation of the endometrium in preparation for implantation of a fertilized ovum. As estrogen rises, a surge occurs, which in turn stimulates a surge in LH that causes ovulation. Immediately following ovulation, the luteal phase starts. That's important. As the corpus luteum forms, the corpus luteum secretes progesterone to maintain the endometrial lining, but is also known to increase basal body temperature. Deficiency of progesterone can lead to a luteal phase defect and infertility. If no implantation occurs, the corpus luteum degrades to corpus albicans and estrogen and progesterone concentration decrease, causing menstruation. So I think it's 44. So it's 2020. Forgot what it was.
Okay, I just okay. During means what happens? FSH and like in follicular phase, there is rise of the follicle, and in here FSH and LH works. Like FSH and LH or uh, FSH and LH increase and stimulate the development of the follicle. Then after in this follicular phase, this follicle actually produces estrogen, and this causing the endometrial proliferation. Okay, for fertilization of the ovum. Then what happens? Immediately following, like after the ovulation, the luteal phase begins. Like for after 14 days, the start of the 15th day, the luteal phase begins, and the corpus luteum actually forms. And then in that 15th phase, the BBT, like basal body temperature, rises. And like the basal body temperature rise is the significance, like uh, when somebody's having the ovulation inducing drug, they are told to do intercourse at the 14, 15, 16 day. Have you heard about this?
No.
Like immediately following ovulation, the luteal phase when begins, then actually people the woman understand that her body temperature is rise, so the ovulation, she is ovulating, as far I know, like people
Mm-hmm.
told that. Okay,
Mm-hmm.
the luteal phase begins and the corpus luteum actually forms. So the corpus luteum
Mm-hmm.
actually secretes the progesterone, and it
Mm-hmm.
maintains the basal body temperature, and then the corpus luteum becomes corpus albicans after menstruation, and these passed out through the menstruation. Okay, we have found one question, like where
Mm-hmm.
is the progesterone is the answer, like what is that? I forgot. Okay, we need to see that question too. Okay, a 32-year-old.
Oh, wait. Do you want it's 40? Wait,
Sorry.
wait. It's 10:40. Do you want to do the biostat now? Because it's
No, no,
10:40. It's
we want to finish this
10:46.
block today.
This block. Okay.
Okay, we'll do bias tomorrow. No problem.
Okay.
We talked a lot. That's why the time passes. Okay, no problem. We need to finish this block today. Okay, 32-year-old woman comes to the physician for a follow-up of 4 months after beginning a trial of trial of oral contraceptive therapy for menometrorrhagia. What does it mean?
I don't know. I guess a lot of bleeding.
Probably. Her symptoms has improved and mens now occur at regular interval, 28 to 30 days of interval, and has and lasts for 3 days. Her last menstrual period was a period. Her last menstrual period was 2 weeks ago. She otherwise healthy and takes no other medication. Physical examination including the pelvic examination shows no abnormality. Which of the following is most likely explanation for the improvement of the patient's bleeding?
Ready?
Okay,
So is the synchronization of the endometrium. Menometrorrhagia can be caused by a variety of structural abnormalities, systemic disorders, endocrine dysfunction such as fibroids, polyps, coagulopathies, and anovulatory cycles. I'm guessing it's a lot of bleeding during menstruation. Is defined by abnormally heavy menstrual periods that occur irregularly. Okay. Evaluation involves pelvic exam and ultrasound. It can be treated with combined OCPs, progesterone, IUD, high dose progesterone therapy, and surgical resection, depending on the underlying pathology. In this case, the combined OCP minimizes the patient bleeding as they resynchronize the endometrium into a typical hormonal cycle. During menses, FSH and LH concentration increase and stimulate the developing follicle. The follicle produces estrogen, which leads to proliferation of the endometrium. In preparation for implantation of a fertilized ovum. Following ovulation, corpus luteum forms. The corpus luteum secretes progesterone to maintain the endometrial lining. If no implantation occurs, the corpus luteum degrades into albicans and estrogen and progesterone concentration decrease, causing menstruation and minor increases in FSH and LH. Combined OCPs prevent ovulation and provide progesterone and estrogen to maintain the endometrium. Wait, prevent ovulation. Okay, which is prevent ovulation and provide progesterone and estrogen to maintain the endometrium, which is locked. Is
Sloughed.
lost when the yeah, it's lost when the contraceptive is withdrawn during the placebo week, resulting in menses.
Can you make me
I don't
understand
understand this.
simply?
I don't understand. I don't understand how the. I mean, I know by reading that the OTP like you know cure the ovulation, whatever. But I don't. I never understood how they do it. I just don't understand.
Okay.
I don't understand. Yeah,
So
and
you
hence
go through the
progesterone
exclusion.
secretion by the corpus luteum. No, no,
You
no, no. I just knew because I read it. I know that OCPs, you know, do something to the endometrium to regulate the menses. Like okay, fine. I
yes.
had issues with my menses, so they gave me OCPs, and that's how I know.
Okay.
But I never understood how they regulate the. I just don't know exactly how they do it.
Okay.
I don't know the mechanism behind that. I don't know. I don't get it. Okay, enhanced progesterone secretion by the corpus luteum will not occur, as the corpus luteum will be less likely to develop because of the suppression of ovulation by the combined OCP. The progesterone required for endometrial maintenance is provided by the oral OCP. So you give estrogen and you give progesterone. So as a
Estrogen
negative feedback,
estrogen helps in follicular phase and progesterone helps in luteal phase, and that's how it works.
doesn't
L-
make sense. How is the? I thought the FSH was the one that helped in the follicular phase.
But you can't give the FSH in terms of contraception. Like if you give estrogen, uh, estrogen negative. Okay, no, that
Yeah, it
doesn't
doesn't
make
make sense. Well,
sense.
look at here. It says increasing LH concentration will not occur as LH is inhibited by the concentration of progesterone and estrogen in the OCPs, which makes sense. Because
Yes,
basically, you are giving estrogen
negative
and
feedback.
progesterone, so
Yes,
negative feedback, so LH and FSH will be low.
low.
So that normally will cause no ovulation. Like,
Yes,
okay, how is that working?
yes, you are on the right track. If you give estrogen and progesterone, it will give negative feedback, so no FSH and LH, no
Okay.
ovulation,
Okay,
no.
so that covers the part where no babies. But how
Yes,
is that covering the part of no mens, like regulate menses?
okay.
You get what
uh,
I'm saying?
yes, like normal
Yeah, because
menstruation.
okay, fine, there is no FSH. Yeah, no FSH, LH, no babies. Okay, we get it. But how is that covering the fact of no, like
like
with the menses? Like,
like if you stop, if you're giving uh, OCP for like 1 month, then you stop the OCP.
mm-hmm.
And then what happens? Your hypothalamus gets activated and start releasing the FSH and LH, and thus, like thinking that way, it is not the accurate way. Like if somebody has diabetes, we what we actually give the metformin. Metformin actually metformin does not help to secrete insulin from the pancreas. It actually block the pancreas, like it actually give the pancreas rest and giving protection from outside. So but in your like in type 2 diabetes mellitus, some of the pancreas is actually active, so that pancreas actually helps in maintaining blood glucose. So like you are giving rest to somebody and then it becomes recharged and start doing its work. That's how I am thinking. May not be a right idea, but can be.
Okay, so when he begins doing his work, how does that help the increased bleeding, the menstrual period?
Like if you block something for a long time, then when it starts working from the beginning, like in a proactive manner. Like it starts secreting FSH and LH in a routine manner. Then the all
Okay.
the system is on the right, the all the system goes accordingly from that. I don't know what I'm talking
Okay.
about. Is that making any
Okay.
sense?
No, I get it. Yeah, I mean, yeah, I think I get what you're saying. I think I get. Yeah, it resets everything. I think I get what you're saying.
Like it is
Yeah,
trying to reset everything. Yes, that's the word, the
everything. Yeah.
reset.
Hmm. Okay. Okay. Next.
A 66-year-old woman, a 66-year-old woman admitted to the hospital because of 2-day history of decreased level of consciousness and dyspnea. 2 years ago, 2 years ago, she was diagnosed with stage 4 epithelial ovarian cancer. And the patient initially responded to surgical debulking and chemotherapy, but she has not responded to past 3 chemotherapy regimens. Her last CT scan of the abdomen showed increase in peritoneal tumor burden. The patient does not have an advanced directive. She appears thin and in moderate respiratory distress. She is unconscious but does not respond to verbal stimuli. Heart temperature is 37, pulse 110, respiration 24, permanent blood pressure 80 by 50. Breathing is labored, breath sounds are decreased in the lower lung filled bilaterally. Her serum CA-125 is 1236 1 month ago, but now is 247. The physician requests family meeting with her 2 daughters. Which of the following is the initial statement by the physician?
Ready?
Okay.
Okay, so it's B as in boy. What do you think is happening with your mom? Jesus. Okay, physicians should begin end life discussion with open-ended questions to assess the understanding of patients or family members of their situation. Physician can then tailor further discussion to address the emotional needs or knowledge gap of patients and family members. For example, some members of the family may not realize that this patient may die immediately and may require education from the physician or
Die
time to
imminently,
process.
probably.
Yeah, I think it means it's the same thing as immediate. I don't know.
Okay,
And
okay.
may
Sorry, sorry.
require education from. I don't know. I think it sounds. I mean, it
I
sounds like the
became a
same.
teacher
I mean,
nowadays.
I don't know. I mean, it sounds like the same. Whatever. I don't know. It may require education from the physician or time to process this news before they can make decisions about their mother's care. Okay. Once the physician ensures all involved parties understand the gravity of the situation, the physician can begin a collaborative discussion about end of life decision that honors the patient and family wishes. Okay. Family, where am I? I want to C and D. Okay. Initially, informing the family members that the mother may die or require life support soon may
Maybe
may
shocking.
be shocking to family. Yeah, may be shocking to our family members who may not yet appreciate the gravity of the situation and preclude further effective discussion about end of life decision. Further, the physician focus should be on the patient and family who require the physician medical rather than potential or whatever. Determine who will make decisions for the patient is an important early step in end of life decisions. However, the physician should first assess family member understanding as they may not realize that the mom has likely lost her decision making capacity permanently and may die soon. Okay, makes sense.
Like before
Next,
giving the organ donation, like you need the advance directive to consult with.
what do you mean?
Okay, leave it. It's a long discussion.
Mm,
Okay, 44.
okay.
I don't
Okay.
want to go into that discussion now. Okay. Oh, an 82-year-old woman, dementia, Alzheimer disease. Sorry. Dem- an 82-year-old woman, dementia, Alzheimer disease, is brought to the physician by her mother because of blood in her underwear. The patient is confused and smells of urine. She is not oriented to time, place, function, but she knows her name. Pelvic examination show severe vaginal atrophy. There is 6 centimeter laceration and the erythematous valve or perineal body. Which of the following is the most likely cause of this patient's finding? Okay,
Okay. So it is sexual assault. This patient presents with perineal erythema, vaginal bleeding, and genital laceration, most likely secondary to mechanical trauma from sexual assault. Further, the odor of urine likely indicates neglect. Elder abuse, neglect, and mistreatment is common. Skin tears, laceration, and bruises in unusual spots suggest elder abuse. Sexual abuse specifically present with pain in the genital area, vaginal and rectal bleeding, and bruises or laceration of the vulva or breast. Elder abuse can exacerbate cognitive impairment and may explain this patient confusion and incontinence. Elderly patients who demonstrate signs of abuse should be interviewed without the caregiver. Physicians are mandated by states to report abuse of vulnerable adults to protective agencies.
okay. Next.
Next.
Yes. A 30-year-old woman comes to the physician for a routine pelvic examination. She has had multiple sexual partners. Perineal examination showed two venereal warts, cervical no abnormality, pap smear show epithelial cells with irregular nuclear contour and a distinct halo around the nucleus with a dense outer rim of cytoplasm. Which of the following is the most likely organism? Okay,
Okay. So the answer is the infection with HPV. Soft pink papillary lesions on the external genitalia are consistent with condyloma acuminata, genital warts associated with HPV that can appear on penis, vagina, vulva, anal canal, multiple sexual partners, and failure to use condom during sexual intercourse are risk factors. The most common implicated strains are 6 and 11, which have low cancer possibility. High risk strains 16, 18, 31, 32 may also be present and indicate an increased risk for progression to CIN and malignancy. In this case, virally infected cells or coilocytes are visible on pap smear as cells with irregular contour and perinuclear halo with the chromatin pushed to the edges of the cell. Viral infection with HPV is the cause of the cytologic atypia seen in this case. In order to identify the atypia, early screening pap smear are recommended every 3 years in women 21 to 29, every 5 years with HPV contesting in 30 to 65. Abnormal pap smear cytology results are commonly confirmed by colposcopy, which allow the visual assessment and biopsy of abnormal lesion. It's not if invasive cervical cancer is classically associated with HPV, the high strains. It presents indolently until advanced, locally invasive or metastatic. Vaginal bleeding or postcoital spotting may be the presenting symptom. It cannot be diagnosed on cytology alone, as invasion must be demonstrated on biopsy or excision. The findings on this pap smear are consistent with atypia from active viral infection.
Okay.
Okay, nice.
3 days after a moderately difficult forceps delivery, a 27-year-old woman, gravida 1, para 1, comes to the physician because of 3-day history of numbness and tingling in anterior lower right leg. She also has had buckling on the right knee when she attempts to walk. Epidural anesthesia is administered during labor. Epidural anesthesia is Epidural anesthesia was administered during labor after 4 days of pushing in the stirrups. During second stage of labor, spinal anesthesia was administered for forceps delivery. Examination showed decreased sensation along the anterior medial aspect of the right thigh, knee, and the upper leg. There is some weakness of the quadriceps femoris muscle. Which of the following is the most likely explanation for this patient?
Ready?
Okay,
Okay, so it's injury to the femoral nerve. Nerve compression injuries are caused by prolonged pressure against the nerve fiber, which results in nerve ischemia and demyelination, which may or may not be reversible depending on the extent of the ischemia. The most commonly injured nerves in the lithotomy position are the femoral nerves and the peroneal nerve. Femoral nerve can be compressed under the inguinal ligament when the hip is flexed greater than 90 degrees, which can lead to numbness of the anterior and medial aspects of the thigh, as well as weakness of the quadricep muscle, as in this patient. Peroneal nerve injuries typically are caused by compression of the fibular head against the stirrup, okay, leading to foot drop and numbness over the dorsal foot and lateral lower extremity. Okay. Recovery of the function of either nerve depends on the length of time that the nerve was exposed to the ischemia. But physical therapy can be useful. It's not A and B. Adverse effects of epidural anesthesia and spinal anesthesia included back pain, headache, hematoma formation, infection, urinary retention, hypotension, and neuropathy. However, the risk for neuropathy is low and it will be more likely to present bilaterally and in the distribution of dermatome instead of within the territory of an individual nerve. Okay.
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 A 28-year-old newly gravid woman has increasingly severe pelvic pain and dyspareunia for past 8 months. During means the patient worsens and she has an occasional episodes of diarrhea. Pelvic examination show normal vagina and cervix with no suspicious lesion. The uterus is normal size, retroverted, fixed, and there is no induration and nodularity of the posterior wall of the uterus and cul-de-sac. There is no palpable adnexal mass. Which of the following is the most appropriate diagnostic test?
Ready?
Yes.
Okay, so is laparoscopy. Endometritis refers to presence of endometrial tissue outside the uterus and classically presents with symptoms of dysmenorrhea, dyspareunia, so painful menses, painful sex, and painful defecation. In physical exam, signs of ectopic endometrial tissue and subsequent fibrosis include palpable nodularity of the posterior uterus and cul-de-sac, along with fixation of the uterus to nearby structures, making it immobile. The standard for diagnosis is a diagnostic laparoscopy, which evaluates for endometriotic implantations on the peritoneum. OCPs can be used for the treatment of endometriosis. Another potential treatment is danazole, which acts to prevent ovary from secreting estradiol by acting as a synthetic androgen and partial androgen receptor agonist. Don't know
Okay.
what that means. Okay, next.
A previously healthy asymmetric 25-year-old woman comes to the physician because a physician for contraceptive advice. She takes no medication means occur at regular 28 days of interval, approximately 5 days. Her last menstrual period was 20 days ago. LV examination shows 5 centimeter mobile mass in the right adnexa. The mass is moderately painful. The mass is moderately painful to palpation. Which of the following is the most likely diagnosis?
Mm, 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 mm. Takes no medications, blah, blah, blah. It was 20 days ago. Mobile mass. And it's painful to palpation. Between F and G. I'm not sure. Ready?
Yes.
Okay. So, I knew. It's endometrioma. The corpus luteum develops from
It,
mature.
it's hemorrhagic luteal
Oh,
cyst.
sorry. Endometrium. I chose endometrioma, so I wanted to be right. The, the corpus luteum develops from mature follicle after the egg has ovulated during the menstrual cycle. In some instances, the corpus luteum can form a cyst which can potentially rupture. A ruptured corpus luteum cyst classically presents with unilateral pelvic or lower abdominal pain that is sudden. Huh? Yeah, that is sudden in onset and severe. Most commonly after sexual intercourse or other physical activity. Physical exam may show a unilateral adnexal or mass, which may be tender. A pelvic ultrasound will show a complex cystic mass or free fluid in the pelvis if rupture, which may include hemorrhagic components. Cholecystectomy, rarely performed, typically produce serosanguinous fluid as the corpus luteum is highly vascular. It's typically managed with observation and supportive therapy. It is not endometrioma, it's a cyst that is formed from ectopic endometrial tissue within the adnexal. Endometriosis commonly presents with dysmenorrhea, dyspareunia, whatever. Additionally, endometriomas are generally adherent to nearby structures and will be less likely to be freely mobile in pelvic exam. Okay.
Okay, how we can differentiate these two? Endometrioma. Because rest of the option is not problem.
Yeah. I guess because it's painful. It's painful. I guess endometrioma will come with signs of endometriosis plus the endometrioma. And the endometrioma will be adherent to adjacent structure. So it will be like stuck to the adjacent structure. It won't be like freely moving. You get what I'm saying?
Okay.
Yeah. And here, usually the corpus luteal cyst, I've noticed in the questions, They usually give you like a young girl,
Young
and they
girl.
will tell you like she just had her period like a few days ago. She just had her menstrual period. They usually give you that for the corpus luteum
So
stage.
young girl, recent period, and a mobile mass in
And the
that
mobile.
direction.
Okay. Mm-hmm. Mm-hmm. Yeah.
Okay.
Okay. Next.
24-year-old primary gravid woman, 12 weeks of gestation, comes to the physician for her prenatal visit. She has immune thrombocytopenic purpura. Wants to know whether this condition will affect the baby. Examination show uterus consistent with 12 weeks of gestation. Which of the patient's fetus is increased risk of which of the following?
Mm-hmm.
Okay.
Okay. Where am I? Oh, fetal placental destruction. Oh, sorry, fetal platelet destruction. ITP, immune thrombocytopenia, is caused by autoantibodies against platelet surface antigen. Oh, wait. ITP and TTP. Okay, I confused. Okay, autoantibodies against platelets, most commonly the GP2B3A. It can be primary or secondary to a variety of disorders such as HIV, Hep C, SLE, CLL. It typically presents with thrombocytopenia with platelet counts that are less than 100,000. Patients often present with petechiae purpura, mucosal bleeding, epistaxis, vaginal bleeding, GI bleeding, which may occasionally result in profound hemorrhage if severe. Labs are otherwise within reference, but bone marrow biopsy often shows megakaryocyte hyperplasia. It can be treated with steroids, IV, IG, but may require splenectomy in refractory cases. As the antibodies responsible for ITP are typically IgG, which can cross the placenta, the fetus is at risk of autoantibody mediated destruction of the platelets.
So in ITP there is autoantibody. These autoantibody can cross the placenta and can cause autoantibody mediated destruction of the platelet.
Mm-hmm. Yeah,
Why it is
okay.
not
And
infarction?
oh, which one? In the here, placental infarction will cause severe uteroplacental insufficiency and potential fetal demise depending on the timing of infarction with regard to the gestational age and delivery. However, in the setting of ITP, placental bleeding would be more likely to occur. Infarction will be by a thrombus, but here you have hemorrhage. You don't have thrombus.
Okay.
Okay. And it's not, yeah. Oh,
You
but
want
it's
to
not anemia.
okay, yes.
Anemia, yeah. Can be seen in the setting of iron deficiency, folic acid deficiency, vitamin B deficiency, chronic systemic illness, and chronic blood. It's not direct consequence of ITP, unless the mother suffers from recurrent mucosal bleeding. Okay, next.
Okay. Last one. A 27-year-old woman gravida to para 2 comes to the physician because of comes to the physician there she is concerned that she may be pregnant. She was sexually active with her husband 2 days ago and did not use contraception. She wants to prevent an unwanted pregnancy. Breastfeeding their 7-month old infant males occur at regular 28 days of interval. Her last menstrual period was 1 week ago. She has a 5-year history of migraines and history of hepatitis B. She was treated with chlamydia trachomatis infection at the age of 17 years. She takes no medication and has no known drug allergy. Vital signs are within normal limit. Physical examination including pelvic physical examination, including pelvic examination shows no abnormality. A urine pregnancy test is negative. I missed lots of things. Like she was treated for chlamydia infection at the age of 17. That's okay. Which of the following is a contraindication of use of levonorgestrel as emergency contraception? History of
Oh.
migraines, isn't it?
I thought migraines was estrogen.
Okay,
Lenovogestrel is progesterone or is estrogen? Or is it both? Maybe it's both. You're right. Maybe it's migraines.
I don't know, but I
I
feel
don't.
like migraine.
I feel like migraines too. You're right. It does sound like migraines.
You were
Okay.
right previously.
Ah!
Don't change the answer.
Ah! Because I feel like the Novogestrel just sound like progesterone only. Okay.
History of
Emergency
migraine. Okay,
emergency contraception can be used after intercourse to prevent pregnancy from occurring, most commonly by altering ovulation and preventing over-fertilization. Primary forms of emergency contraception include levonorgestrel, ulipristal, and copper IUD. Oh, and levonorgestrel prevents ovulation and can be taken up to like 3 days after intercourse, although it's less effective at preventing pregnancy than the other methods. It has no significant contraindication and is safe to use in breastfeeding women, making it acceptable choice for this patient. Adverse effects include nausea, irregular menstrual bleeding, lower abdominal pain, fatigue. Ulipristal is an antiprogesterone that also prevents ovulation. It can be used up to 5 days after intercourse. It has no significant contraindication. Adverse effects are like those for levonorgestrel. And copper IUD is the most effective form of emergency contraception and its use can be continued for long-term contraception. It is effective if placed within 5 days of intercourse and has few contraindications, with exception including active uterine infection or an underlying anatomic abnormality like septic uterus. Adverse effects include abdominal cramping, vaginal bleeding, infection, and uterine perforation. And it's not, they didn't even put E here. Never mind.
okay,
Okay.
okay, we are
Yes, we
done.
have. Yep.